after you've finished doing this, again, wait another couple of weeks, allow your case to rest. Now, the last bit. Remember, I need to find you interesting. You need to make it easy for me to pass you. You need to show me that you've learned something. You need to make me think that you're safe. And you really need to avoid any spelling or grammatical mistakes because these things really prejudice us pretty early. So mark your own case, use the marking scheme, see whether or not did you learn anything, give it to your supervisors for comments, and then submit it. And after you submit it, you may pass. And if you don't pass, this is why. As I said before, it's very, very tiring work. There's a large quantity of material that we have to wade through. And from an early start, it's very apparent in the first few pages whether or not a case is likely to be one that is going to end up being passed. If there's a lack of polish, if there are spelling and grammatical mistakes, we very quickly lose interest, which is why the very second thing on the marking scheme is poor language, because with that, it's considered inaccessible. Now, the reason why we're motivated to do this is because we are inspired by the diligence and wit of our bright, shining trainees. Equally, we don't want people who are unsafe to continue with doing things. But it's not that hard to pass the second time. Because what we do is that we usually have, and we are required to, and whenever we do decide to fail a person, it actually has to go to a third examiner for confirmation of them. And we have to create it's actually harder for us to pass, it's harder for us to fail patients than to pass them. Because we have to have lengthy, peer-reviewed processes by what sort of changes need to be made to the case in order for the case to be passed. Unless there were major problems, such as sweeping statements regarding case organization, you usually just have to look at what the recommendations are and respond to them, together with including an explanatory note advising about how you responded to them. If there are really major problems, you may need to think about rewriting your case from scratch, which is not such a hard deal. In your regular public work, you currently do about 4,000 to 8,000 words per week anyway. It is a bit of time, but it is not an impossible task, is what I'm basically saying. And what your task basically is to try to show that you have responded to the feedback. And there also exist professional editors out there that you can give your material to for correcting your spelling and grammar, particularly if English is a second language for you. Make use of these. They do make a massive difference for the case. So last comments. Psychotherapy may not be an intervention you plan to give to your patients longer term. But the thing is that regardless of whether or not you plan to, the better you do it, the more it improves your clinical acumen. I found that as a result of going through and having good supervision myself and my first psychotherapy patient, my capacity to assess and pick up minor elements of depression and understand personality from a positive and from a functional perspective greatly increased. There are things like the third observer where you start to analyze how you relate to patients to a meaningful fashion. There's improved capacity for mental state examination. You understand what defense mechanisms are. You understand what to do with them. And your ability to evaluate personality styles and to adapt your approach for more beneficial outcomes. So this one's my company. So I provide psychotherapy supervision on a private basis, and now I also do psychotherapy case reviews. If you want me to be looking at your cases and provide you with video conference guide updating on it, and you can also have a look on my website that we regularly put up writings and resources on psychiatry and psychotherapy. Any last questions? Yes.
Thank you for the talk. I was recently advised by one of the fellow markers as well that it might be good to finish writing up your case and then take a year break, and when you've hopefully developed maturity to look at it again. What are your thoughts on that sort of time frame?
Yeah, it makes sense because you do need a fair amount of maturity in order to be able to understand it. But it's not just about maturity, it's basically about your capacity for emotional reflection. If you are conducting the therapy and documenting it well, in terms of documenting your own emotional reactions to the patients and seeing how you change from beginning to end, that's not usually as much of a problem. I do certainly recommend a delay after writing your case. You probably might not need as long as about a year, but you do need to continue to be reading and writing and increasing your psychotherapeutic knowledge in order to answer all these questions inside there. There is a large bank of psychotherapeutic theory. I do recommend Gabbard's Long-Term Psychodynamic Therapy basic text. The third edition includes a DVD that's really helpful, but the second edition has all the material that you need as well. That covers all the theory realistically that you need for the purposes of this case. So in terms of the maturity question, it's really about documenting your own emotional responses to the thing and marrying them with the right level of psychotherapeutic theory in order to write up your case effectively. Yeah.
Thank you.
I'll just bring that to you.
I just want to know, does it need to be exactly 40 sessions, or can it be 41 or 42, 45?
Yeah, there isn't any issue at all with it going over. There is I try to recommend avoiding going over, mostly because the quality of the therapy drops away once you feel that it's not completely necessary for yourself to provide the therapy to this patient anymore. So that's why I tend to recommend a fairly strict number of sessions. There are quite a lot of circumstances where you have a drop in sessions where the patient terminates at 37 or 38 or 30 or perhaps even less than that. There is a specific clause inside there where you can actually appeal to the psychotherapeutic committee, advising them of the patient termination at this early stage, and they will review that and determine whether or not you want to have your case through. That's because in the past, I actually know one registrar who had 6 patients terminate at about session 30, simply because his therapy was too good. And it was because of circumstances like that they brought this in. So it's not as much of an issue now, but the college does respond to and has a framework for it, and we are pretty lenient on that. As long as it's clear that it's for patient benefit purposes and not just because the registrar got lazy or wanted to try to finish something early. Having said that, there are also a number of cases which have been turned down because it was clear that there were massive problems with patient selection from the start. So that's why it's also important to document the interaction with the supervisor and the rationale for deciding on proceeding with this and whether there were clearly avoidable things that weren't taken up on.
When I did my psychotherapy case, this was in the UK, I think the patient finished at about 12 sessions or something, wrote a letter, possibly flight into health or whatever, but we didn't have rules, like that where you had to do 40 or whatever. But I was asked by the psychotherapist to sit in the room and think about the patient. Do you know if that will pass through?
Yeah, Samuel Shem did that in House of God too, in that Mount of Misery thing. Yeah, there are lots of weird analysts out there.
Oh, hi. Thanks for the talk. I was just hoping to inquire, in response to what you said about if someone fails you and knocks back on your case.
Yep.
And then they've got your old case and things. When you rewrite your case, are you expected to make a comment on why you failed the past case?
Yeah, there is a feedback form that comes back.
No. As in, when you rewrite your case,
right?
Are you expected to? I suppose, put it another way, are you supposed to put a section in your new rewritten case and say you've reflected on why you failed in your previous write-up, and this is what you've learned in your new write-up?
No, it's not a requirement, but it's a good idea to do so because you're not expected to put something inside your case about that specifically. But there is a resubmission form that you can add, and you can add. It's sort of like similar to editor comment type thing, and that's not part of your formal case. So what we get is that we get your old case together with the case examiner comments from that case, together with your newest case. It is a good idea to add on top of that something about that I responded to these statements in this way, it will not be considered part of your main case, but it will add to the it will add to the experience of recognizing that this was this was a registrar who took this task seriously and responded to it appropriately.
Sorry, Raj. Just...
I'm just nearing the end of my first year of training. At what part of the training do you suggest like getting something started upon?
Yeah, I think it's a good idea to try to start doing your psychotherapy case in the beginning of second year. And I think it's important to try getting psychotherapy supervision at least halfway through your first year. You need a fair amount of theory before you start seeing patients. You need to listen to the experience of other registrars. Like particularly if you have opportunity for group supervision, this is ideal. You need to have opportunities to listen to how other people do interpretations and understanding about what the process is well before you see your first patient. And your first patient is likely to fail. Doesn't mean that they will, but that's why it's a good idea to try to do it as early as possible, but only after you have the right amount of theory in place. Your first year is usually spent on first learning the fundamentals of basic psychiatry training and knowing how to do a mental state examination. So if you try to throw psychoanalytic material inside that, it's going to interfere with those basic skills. You need to have those basic skills first and layer on top of it with your psychotherapeutic skills in order to be able to have a good experience with the patient.
Thank you.
Sorry?
Sorry.
Schema therapy is not psychodynamic. Schema therapy is a mechanism of using psychodynamic principles via a predefined model that is actually closer to a CBT format in order to adapt patient personality styles to particular defense mechanisms for a small amount of insight generation. But there's no unconscious material. So there's no, by definition, if there's no unconscious material, it's not a dynamic intervention.
Can we still choose to submit it because the colleagues see it as a long-term psychotherapy, not a psychotherapy?
It'd be extremely risky because schema therapy is seen as a brief supportive intervention. It's not seen as a long-term psychodynamic therapy. Yeah, there obviously are variations to this. I mean, there are over 160 kinds of psychotherapy out there, and you have everyone having their own perspectives. But I can tell you that the majority of the examiners would not look favorably on schema therapy being promoted as a long-term psychodynamic intervention. Yeah, the dynamic intervention it's not too hard. Go from the Gabbard model, and that's the closest to what everyone else would have. I know there's a Kleinian, for example, on the examination committee, and there's a Jungian. It's not the Jungian doesn't do it anymore. There are a few different ones inside there, but what we all agree on is insight, transference, countertransference, resistance, defense mechanisms. So that's why the Gabbard school is such a good idea, because the Gabbard school is a incontrovertible, fairly well-recognized model of psychodynamic care that cuts across all the models and is going to be the safest for the patient and the easiest for you to understand as well. And it appropriately uses previous analytic things without getting too bogged down in one particular model and saying that you need to keep on analyzing this attachment, those sorts of things, which gets really complicated and it's going to cause more problems for you in the longer term, and particularly in terms of the writing of the case. So go with so I wouldn't. Schema therapy probably would have been done back when we used to have the short term. We used to be able to do a couple of short term cases instead of a long term case. But for long term, I wouldn't be advising that. Yeah. Sorry.
Sorry. So just to clarify with what you just said. So I thought you had to explain which model you chose and why and how you use it, and that it's not recommended to use more than one model because it gets messy. So you're saying to just say, what would you call Gabbard's model?
Gabbard's model is long-term psychodynamic psychotherapy, and it's easily referenced, it's well recognized, and he's very nice. So yeah, he's really nice, like amazingly nice. you're not going to have any issues with going through that. The problem is that if you really want to use the models, then go for it.
Yeah.
But I haven't a clue what specific Kleinian interpretations of a narcissistic personality disorder subtype with a secondary brittle shell formulation according to the Kernbergian model, or opposed to the secondary Kohutian model pre-1980 or post-1980. And those are all real things. I didn't make them up. They're all actual real things. So if you want to go to those kind of models, then great. I'd have to do a lot of reading to know how to pass your case. You probably would know what you're talking about, but it's so much more dangerous, and it's throwing a lot of detail and difficulty in your way, which you don't need. It's easier to go with a form of therapy that is easier to understand, that cuts across, that uses fundamental concepts that are common to many psychodynamic models, rather than to go all Kleinian or all Jungian or all pre or post. I mean, even you go Freudian, there's a difference between Sigmund and Anna, for example. With one, you can use drive, with the other, you can't. So yeah, that's what makes it so much more complex. It's just easier to stick to the basics of insight and transference.
Great, thanks.
All right. Thank you very much, Neil. We'll take the opportunity to thank Neil for his excellent presentation. I think there are a lot of lessons in this, and obviously you've got an excellent roadmap, with Neil's slides. So please use that. Some great questions there. So thank you very much, Neil, for that excellent presentation. And of course, make sure you use the resource as well. He loves psychotherapy, so please send him as much information as you can. Thanks very much.